which we are having. And I think this is their 8th webinar throughout this year. They are conducting it sincerely every month with IMA Pune. And we really appreciate them for these efforts they are taking to bring new faculty and good topics every month to IMA Pune members. This time also we are having good talks by, first of all, by Dr. Shirish Sathe on optimizing heart failure therapy simultaneously with the speed. Then Dr. Hemant Kulkarni will be talking on minimizing the advancement of heart disease with dyslipidemia and CAD management. Then Dr. Anuja Murray will be talking on lowering risk of stent thrombosis, learning from a case. Dr. Sriram Godbole will be talking on treatment intensification with SGLT21 and DPP41. And Dr. A.J. Unikrishnan will be talking on non-diabetic CKD. Is there any hope on the horizon with dapagliflozin? So I think those are very good topics, excellent speakers, excellent faculties, and we welcome you all to this webinar today. And I hope many of you who have registered join fast, because it's don't miss out on those first initial talk by Dr. Shirish Sathe. And also we would all request you to even register for our Multicon, which is coming on the 7th and 8th January 2023. And it's our annual conference. The pre-conference workshop is on 25th of December. And this is going to be a totally physical conference. So kudos and join fast and register fast. So here we go on to the webinar now. Thank you.
Hello.
Thank you, madam. Yes.
हॅलो सर, मी पंकज बोलतोय. मनीष सरांनी जे पाठवलंय ना त्याला फक्त ऍक्सेस द्यावा लागेल, मग स्लाइड ओपन होते. पियुष सरांनी त्यांना रिक्वेस्ट पाठवली आहे गुगल ड्राईव्ह वर.
Okay. That way. I'll talk to him. Give me a minute. Yeah, he will do it. He's got the message. Dr. Deshpande, have you started, IMA has started physical meetings or they're still?
Yes, sir. We have started physically now.
No.
And we are getting good response for physical also now, attendance. Slowly they are increasing in numbers. We are encouraging everybody to come and register physically for the Multicon at least, because that will be our annual conference. And we have already got more than 120 registrations at hand.
Oh, that's good. And it's physical.
It's physical.
Yes. Only physical.
At IMA Pune itself, at this building.
So last Sunday also we had arranged organ transplant CME. So that was also physical. Along with that, we took a public awareness program on organ donation. So there also we had about 100 people joining. Physically only. It was also only physical.
That's great. That's very good. I think.
Can we start, sir? So can I start now with introduction of yours?
Pankaj, no, just check with
Pankaj. रिक्वेस्ट ऍक्सेस नाही झाली अजून. जी रिक्वेस्ट केली होती ना ऍक्सेस करायची गुगल ड्राईव्हची, ती अजून ऍक्सेप्ट नाही केलेली आहे. त्यामुळे ते ओपन नाही होत. जेव्हा तो ऍक्सेप्ट करतील तर लगेच ओपन करता येईल.
पण त्यांनी तो म्हणला मी करतो म्हणून.
हा, ऍक्च्युली एक इम्तियाज कित्तूर यांच्या नावाने गेली आहे आणि एक पियुष काळे यांच्या नावाने पण गेली असणार आहे. कारण की आम्ही पण यासाठी ट्राय करतोय आणि पियुष सर पण तिकडून ट्राय करतोय.
परवानगी दिली का ऍक्सेस करायला? बर, कोण? पंकज? पंकज
सर. येस सर.
मनीषशी बोल ना.
हा सर. इम्तियाज कित्तूर सरांनी तुम्हाला रिक्वेस्ट दिली असेल ऍक्सेस करण्याची. त्याला फक्त तुम्ही ओके करा, तर म्हणजे आम्ही इकडे स्लाइड अपलोड करू शकू. तुम्हाला 2 रिक्वेस्ट आले असेल.
तुला 2 रिक्वेस्ट आल्यात ओके करायचे.
आयदर इम्तियाज कितूर किंवा पियुष काळे.
राईट लाईट मीडियाच्या नावाने रिक्वेस्ट आहे.
पियुष काळेलाच करते ना काय? पियुष
राईट लाईट मीडियाच्या नावाने रिक्वेस्ट आहे.
एक मिनिट, तुला ऐकू येतं त्यांचं बोलणं? ते सांगतील काय करायचं.
राईट लाईट मीडिया.
सर राईट लाईट मीडिया वरून ऍक्सेसची रिक्वेस्ट आलेली असणार आहे ईमेल वरती तुम्हाला. ओके.
मग दिसतंय का तुला?
नाही मी 1 मिनिट जस्ट चालू करतोय सर मेल माझा.
हा
जस्ट 1 मिनिट.
हा मेल केलंय. दोघांचं मेल आलेत तुला.
मेल मध्ये तर नाही ऍक्च्युअली.
म्हणजे
manish@gmail.com या आयडी वरती.
डॉक्टर देशपांडे.
येस सर बोला.
येस येस सर.
सेकंड स्पीकरचा मग पहिल्यांदा घ्यायचंय का टॉक?
हा आय थिंक काय त्रास हे कळत नाहीये. But in the meanwhile, we can sort it out. Okay. So if second speaker is ready,
just see whether the second speaker can join and share the slides.
Dr. Hemant Kulkarni, Mr. Pankaj sir, please request Dr. Hemant Kulkarni sir to join.
Okay, okay, ma'am. Just
yeah.
Hello.
Ask him to make the host also. Ask to make the speakers all as host, so that does not require time.
That is not necessary.
Already
That
host.
is allowed.
Only thing that AstraZeneca link is not getting accessed. We are not getting access to that link. Sir also is not getting. We tried and that is in process. Yes, I think he has started all.
Yes, I think Dr. Sate's slides are seen now. So we can introduce him now, I think.
Sir.
Yes, I don't know how you got it, but you got it.
Yes, sir. Sir, ultimately we are. I'll be introducing you, sir.
Yeah, sure.
Yes. Good afternoon, everyone, and welcome to this webinar. Dr. Shirish Sate, sir, is a MD Medicine with gold medal from University of Pune, DM Cardiology. CMC Vellore, Fellowship in Interventional
Sir,
Cardiology,
sorry, sir.
Sydney University.
Yes.
He has got, he's a practicing well-known cardiologist from Pune for more than 30 years. Equally interested in complex interventions with special interest in primary angioplasty as well as pharmacotherapy of heart failure, dyslipidemia, and non-ischemic cardiac diseases. Conducting DNB cardiology program, multiple international clinical trials, and a heart failure clinic at DMH. Director of Cardiology at Dinanath Mangeshkar Hospital for last 20 years, right from its inception. So thank you very much, sir, and welcome, sir. And you can start, sir.
Thank you. Thank you. Can you make it large?
Yes.
Presentation mode.
Imtiaz,
Actually,
can you?
sir, yes, sir. Actually, we are trying, but sir, we're not able to find where to large mode is.
Aniket, please.
Okay, I think we can do with that.
Right side, la.
Sir, click on slideshow on the top right.
So,
Slideshow.
वो करते तो होत नहीं है. How is to do? Yeah. That's yes. It is.
It's loading.
Screen now.
Okay, I think I can start. Good afternoon, everybody. And at the outset, let me thank office bearers of IMA and, of course, AstraZeneca to call me here for the meeting. Appears to be a very interesting and exciting meeting today. Heart failure is an ancient disease, but the treatment for heart failure started way back in 1785. So 1785 is the year when digoxin was discovered. Since then, digoxin was the only medicine that was available for heart failure till almost 1960. So nothing really happened in between. In 1960s, diuretics came in. So diuretics came in as a symptomatic relief of congestive heart failure. So then we have for next almost 20 years only digoxin and diuretic. But most of the trials of these two molecules have shown that they just do symptomatic relief of dyspnea, but there is no improvement in the mortality. So no mortality benefit, even if patients are on digoxin and diuretic. It is in 1985 onwards that another molecule came in, and that is a beta blocker. And it is surprising really, or it is ironic that molecule which was contraindicated in heart failure finally was extremely useful in heart failure. So all the trials came in 1985 to 1990, and that was the first molecule which actually changed the scene. It showed significant mortality benefit for the first time. 1990s was the decade of ACE inhibitors and ARBs. Multiple trials in congestive heart failure also showed a significant reduction in mortality. So again, another molecule which showed mortality benefit. At the turn of the century, early 2001, 2002, another molecule came called MRA, which is eplerenone. So the big trial on eplerenone also showed that there is a mortality benefit. Then next 10 to 12 years, nothing really happened. And then Paradigm HF trial came, a landmark trial, which is on ARNI, and which showed that on top of all these molecules, there was again more reduction in mortality. Then of course, in last 2 3 years, SGLT2 inhibitors have come in with a robust data. So I think this is a golden era for patients with heart failure. Can you show the next slide? We have multiple molecules which are available with us. And before we really talk about all this heart failure therapy, let us just brush up our memories and what is new in the definition of heart failure, how do we classify heart failure, etc. So this is the latest staging of heart failure. This is 2021 and 2022 ACC-AHA guidelines. They tell us that now there are 4 stages. of heart failure, stage A, B, C, and D. A is actually no heart failure, but the patients who are at a risk of heart failure. That is patients with hypertension, CVD, diabetes, obesity, etc. Stage B is actually pre-heart failure. Again, there are no symptoms as such, but there are risk factors which can tell us, especially biomarkers which can tell us that there is actually asymptomatic heart failure. There is underlying structural heart disease as well. Stage C is symptomatic heart failure, and stage D is advanced heart failure. Next. There is a classification of heart failure done by LV ejection fraction. So now these terminologies are important because these are the terminologies which we keep using internationally. So if ejection fraction is less than 40%, we call it heart failure with reduced ejection fraction, or it is called as HFrEF, HFrEF. If a patient has reduced ejection fraction less than 40%, but with treatment on a follow-up, he shows that LVEF has now improved to more than 40%. It is called heart failure. Still, it is heart failure, but with improved ejection fraction, HFIMP-EF. If ejection fraction is between 40 to 50, this is called now mildly reduced. So even anything below 50 now is called as reduced ejection fraction or reduced ejection fraction with heart failure. So this is HFMREF, which is heart failure with mildly reduced ejection fraction. And of course, if ejection fraction is more than 50%, and if the patient comes with heart failure, and that can happen as we all know, it is called as HFpEF, or heart failure with reserved ejection fractions. So all these terminologies are really important to know, because internationally when we talk about heart failure, we talk about these different classes of heart failure. Next. So you can see here the same thing, initial classification, and now with serial assessment, there is a reclassification, same thing. Next. And it is really a major global health problem. We all know that it is growing in nature. The world burden of heart failure is actually increasing so much that it has overtaken ischemic heart burden of the world. We keep talking about heart failure, we keep talking about myocardial infarction, ischemic heart disease, and we talk less about heart failure. But actually the heart failure burden of the world is more than the burden of ischemic heart disease. Next. So it's a major global health problem. Since 1990, there is a 36% rise in heart failure. By 2030, another 10% will be added, and by 2030, HF prevalence is expected to increase by a further 15%. So it just keeps on increasing. Next. And of course, India is no exception to that. There are at least 8 to 10 million patients with heart failure in India. Prevalence of about 1% adult population. That's very high. Heart failure in India has a post-admission mortality of 20 to 30%, much more than ischemic heart disease. Medication adherence is very poor in India, just 25 to 50%. The prevalence of heart failure in patients was 22.5% below 30 years. And this is how it is different from rest of the world. India has a relatively young population of heart failures. Next. And you can see here that heart failure patients are at a very high risk of death and hospitalization. 9 out of 10 patients are symptomatic, even with current medical treatment. Nearly 1/3 of patients with heart failure are at a high risk of hospitalization or CV death, including those who appear stable. Even stable patient is at a risk of hospitalization. And with each hospitalization, you can see on the right side that the mortality, the mean survival goes on decreasing. After first heart failure hospitalization, mean survival is 2.6 years. And after fourth hospitalization, it goes down to just 1.3 years. That is the impact of heart failure and the gravity of situation when a patient presents with heart failure. Next. I won't go into the details of that because we all know that it is all interrelated. Heart, brain, kidneys, and blood vessels, and there are receptors everywhere. And we actually, with all our medications which are available with us, are attacking or trying to modify all these receptors in various organs. Next. We also know, next, that heart failure, next, and kidney are also very closely related. It has got implications in the management that we do, the treatment that we give, the molecules that we use. But it has got effects. The kidney has got effects on heart, heart has got effects on kidney. So it's a kind of a vicious cycle. Next. Next. With this background, I think let's go back to the treatment. What are the different molecules that are available with us? And as I told that till say 2013, 2012, we had 4 molecules. And you can see here that beta blockers has got the maximum mortality reduction. MRAs are following that, and then ACE inhibitors or ARBs. Next. When ARNI came, angiotensin neprilysin inhibitor, it showed 20% additional mortality benefit on top of ACE inhibitors, more than ACE inhibitors. Next. So ARNI has become one of the best medicines that are available to us, one of the best medicines, in addition to 3 medicines that were already available. And the trial which showed it was Paradigm HF, the one on the left side. And in last 2-3 years now, we have got 2 more trials, milestone trials, DAPA HF, which is on dapagliflozin, and Emperor Reduced, which is on empagliflozin. And both of them, these both are SGLT2 inhibitors. You can see that they have shown again significant reduction in mortality also. On top of all these medicines which are already available. So till 2020, 2021, last just 2 years, 3 years, we have these 2 beautiful trials which have shown that SGLT2 has become an important pillar of treatment of heart failure. Next. As I said, Paradigm HF is a milestone study for angiotensin receptor neprilysin inhibition, or it is called as ARNI. Next. And it showed in the left upper quadrant, you can see that it showed that there is a significant reduction in the mortality. And in fact, in all kinds of MACE, there is a significant reduction over ACE inhibitor. Next. This is where it shows that CV death or hospitalization for heart failure was reduced with a p-value of 0.001. Even CV death was reduced with a p-value of 0.001. This is on top of ACE inhibitor or when compared to ACE inhibitor. Even hospitalization for heart failure has also significantly reduced again with a p-value of 0.001. So among the participants with reduced ejection fraction and NYHA class 2, class 4, the use of ARNI was beneficial compared to enalapril. Next. Then these are the 2 trials on SGLT2 inhibitors, Emperor Reduced and DAPA HF. Similar results. The only thing that you can see that eGFR, if you can look down at the bottom part of the slide, that eGFR for DAPA was 30 and above. Now, nobody talks about creatinine nowadays. We talk about eGFR. So if eGFR is above 30, then only you can give dapagliflozin. For empagliflozin, on the other hand, If eGFR up to 20 also, you can give empagliflozin. It's important. As I said, kidney and heart are very closely related, and many times situation comes when patients have heart failure and CKD, and therein these molecules are really important, because ACE inhibitors again, or even MRAs, you cannot use when the eGFR is less than 30 ml. So those two molecules also you cannot give. ACE inhibitor, ARNI or MRA, you cannot give. You can give only beta blocker at whatever eGFR. Next. Same thing, 30 and 20, easy to remember. Next. So these four molecules are now called the foundational therapy for patients with HFrEF. There are multiple international evidence-based guidelines agree on these four foundational drug classes for patients with heart failure. You can see here the RAS inhibitors, or whatever you call it, ACE inhibitor, RAS and ARNI, MRA, beta blocker, and SGLT2 inhibitor. Next. So this is the foundation of therapy of heart failure. Of course, diuretics are there, and these are 2022 guidelines. So these are the latest as late can be. So diuretics, of course, only for decongestion is a class 1 indication. Next. ACE inhibitor, again, class 1, evidence, level of evidence A. So on top, ARNI on top. Yes. Next. In patients with previous or current symptoms of heart failure who are intolerant to ACE inhibitor because of cough or angioedema, and when the use of ARNI is not feasible, that is the only indications for ARB. It's important to know, because we have seen in our clinical practice, there are many clinicians who start with ARB for a patient of heart failure. ARB, you can say, is inferior, and it is indicated only if patient is intolerant to either ACE inhibitor or ARB. Please remember that. Next. In fact, ACE inhibitor, ARB, or ARNI are almost contraindicated and cause harm if, especially ARNI, it should not be administered concomitantly with ACE inhibitor, or even within 36 hours of the last dose of ACE inhibitor. So you have to stop ACE inhibitor, wait for 36 to 48 hours, and then start ARNI. ARNI should not be administered in patients with any history of angioedema, because that is one of the side effects of ARNI. ACE inhibitor should not be administered to patients with any history. Same thing, it may cause harm. Next. Beta blocker, again, class 1, level of evidence C. Significant, robust evidence in favor of beta blocker. Now, do all beta blockers are helpful in heart failure? No. I think evidence at least tells us that there are 3 molecules: bisoprolol, carvedilol, and sustained release metoprolol. These are the only 3 molecules which have been proven in multiple trials to be useful in heart failure, in reducing mortality, significant reduction in mortality that we have seen. So it's a class 1A indication. Next. MRA again, excellent results. Again, class 1A. But as I said, that eGFR has to be more than 30. And the second thing is potassium. So you look for 2 things in if you have to start MRA. One is eGFR, which should be more than 30, and potassium, which should be less than 5. Then and then only you can do it. But in patients taking NRA, whose serum potassium cannot be maintained at less than 5.5, MRA should be discontinued to avoid life-threatening hyperkalemia. It may cause harm. So 5.5 is cut off, but the safer thing is to start it when potassium is less than 5. Next. SGLT2 inhibitors, again, the latest drug, although still it has got class 1A recommendation. High recommendation for SGLT2 inhibitor as well. Next. So these were the 4 molecules which showed it. But even after using all these 4 molecules, you can see on the right-hand side that there is still a significant residual risk. There are patients who are on these 4 molecules and still they have problems, they have mortality, they have repeat hospitalization. So there is unmet need of more new molecules. Next. Same thing here with Baradine, DAPA-HF, Emperor reduced. There is still a significant residual risk which persists. Next. So there are 2 more molecules which have come now. On the right-hand side, you can see. One is vericiguat, which is in a Victoria study, and the other is omecamtiv, which is in a Galactic study. Now, these are smaller studies in subset of patients, and they have shown significant results in reduction in little bit of reduction in mortality, but mainly reduction in hospitalization, re-hospitalization. And we need more data for these 2 molecules to get them to be equal to the 4 foundation therapies that we are talking about. Next, but they are there, they are useful in some such subsets of patients. Next. These are, as I said, apart from those 4, these are other medications like ivabradine, vericiguat, digoxin, sometimes in some patients, hydralazine, isosorbate dinitrate. There are potassium binders which we can give, get the potassium down and restart MRA, anticoagulants, and importantly IVI. So these are also some of the other additional medications which you can give in some subsets of patients. We'll see which subsets. Next. So hydralazine actually is useful only in African Americans. There is only one study in African Americans way back in 1995. After that, there are no studies on hydralazine, but still it is recommended only in African Americans by ACCHA. In India, we do use it when there is no other alternative. When other medicines cannot be given, we still don't know whether that will be useful in India or not, but we sometimes do give it. Next. So in patients with heart failure who experience hyperkalemia, as I said, there are potassium binders which you can give. But again, you can see on the left-hand side that the recommendation is 2B. And what is 2B? 2B means may be considered. May be considered. If it is more than 5.5, if you want to give MRA, then give potassium binders and then restart MRS. May be considered, not class A. There is no evidence. Next. Which are receiving GDMT with a beta blocker. And now this is important, ivabradine. I personally feel that ivabradine in India is grossly abused by clinicians. Many clinicians start ivabradine instead of a beta blocker. And that is absolutely wrong. It's not good. You're not doing any service to the patient. It is disservice to the patient. Ivabradine is indicated only when a beta blocker is given to its maximal tolerated dose in a sinus rhythm patient, and still the heart rate is more than 70. So if the BP goes down to 90, you cannot increase beta blocker, then and then only ivabradine is indicated. And you can see here that the recommendation also is 2A. 2A means should be considered. Should be considered. It is not class 1 at all. It is not equivalent to beta blocker at all. It should not be started offhand without trying beta blocker. Next. Digoxin has not much role, but might be considered to decrease hospitalization despite guideline-directed medical treatment. If patients keep coming with increase, you may try it just to symptomatic relief. So it has gone almost out now, digoxin, which was the only drug which was available for almost 180 years. Next. And this is the new class, very Suguard. Again, it is 2B. So it may be considered in a very highly selective patients of high-risk patients who come with worsening of heart failure. This, I think, it's a very good molecule. The trial is in worsening heart failure. So maybe we need a good studies on this particular molecule and maybe get it in the mainstream. Next. Okay, so there are drugs which are unproven and still which are used, but there are which should not be used. Calcium channel blocker have negative inotropic activity, so they should not be used. Similarly, vitamins, nutritional supplements, hormonal therapy are not recommended, they are useless. And some of the calcium channel blockers like calaptin, isosortin, etc., they may do harm than do any good. So please remember, calcium channel blockers and other supplements should not be used. Next. Antiarrhythmics class 1C may increase mortality. Some diuretics may increase mortality. They cause harm. DPP-4, remember, it may cause harm in congestive heart failure. Similarly, NSAIDs may worsen heart failure symptoms. So all these medicines should be avoided. Next. These are the doses, and starting dose and target dose are important. It's not possible for me to go through all these dosages, but one message I would like to give is start with a smaller dose, but always and always try to go for target dose. Target dose, going to target is very important. Next. Next. Okay, so in a nutshell, this is what you are treating with the what are called as fabulous 4 or the foundational 4 molecules. And on the sides, you can see that you can give iron in a patient, and there are indications to give iron. You can give hydrolyzine in some self-identified blacks. Anticoagulant sometimes useful in AF. Digitalis in AF. CRT, ivabradine only when heart rate is more than 70. CRT only when QRS duration is more than 150. Loop diuretics, thiazide, vericiguat, omecamtiv, these are some of the newer medications which have a small role to play, or at least a role to play in subsets of patients of heart failure. But the main therapy is the 4 fabulous. Next. So the fabulous 4. And this is again depiction of the same thing when you should start these. Next. I think to me it is very simple. Tailor-made medical therapy according to clinical profile. All you need to know in a patient of heart failure is what is his heart rate. If heart rate is above 70, then start beta blocker. BP. BP has to be above 90 to 100 systolic to start any medication, especially ACE inhibitors, beta blockers, ARNI, because they may get your BP down. And BP, you can keep increasing. Start with a small dose, depending on BP. If it is falling below 90 or if the patient is symptomatic, then you should stop it. Third is atrial fibrillation. If there is atrial fibrillation, then you have to use other medications for atrial fibrillation in addition to what you can give. And lastly, CKD and potassium. So these are the only simple things that one should look at and decide or initiate your therapy with all 4 medications as and when required. If there is CKD, there are very little options really, especially if eGFR is below 20. Then you cannot use most of the medications except beta blocker and diuretics and vericiguat. So, but up to 30 eGFR, you can use SGLT2 inhibitors easily and safely, and above 30, you can use all medicines. Potassium has to be less than 5 if you have to start eplerenone. Otherwise, other medicines can be started. So it's really very simple. Next. It's not a rocket medicine really. You can just look at these 4 things and start your medication. Next. The conventionally, now we have 4 molecules, but how do we really initiate? If you look at the left side, conventionally there used to be a sequencing. So start with ACE inhibitor, then add beta blocker, then maybe MRA, and maybe lastly SGLT2 inhibitor or ARNI. That has been a story for a very long time, over last few years. Next, when the SGLT2 and ARNI have got available now. And normally the trend was to have 4 drugs on board in 4 weeks. Next. But you can see here, that it is better to have more than 1 molecule at a time. If you start with 1 molecule and keep up titrating it, it won't have those many benefits. Instead, if you start all 4 medicines together at a lower dose, maybe initiating dose, that will have much more benefit. So nowadays, next, the things are changing. Because there are limitations of traditional FREF therapy sequencing. The conventional sequencing for initiating FREF therapy is by order in which they were tested in the clinical trials. Prescribers are advised to titrate each drug to the target dose and then add on to another therapy. But this has many limitations. There is a delay in starting therapies demonstrated to reduce mortality morbidity, which is there even in the first 30 days. Assumes that the most effective and well-tolerated treatments were developed first, but it is not true. Assumes that foundational treatments are effective only when titrated to target dosages, which is also not true. Even if we give half doses of all 4, they are much better than a target dose of 1 single molecule. It also assumes that each drug was tested in an environment where patients were receiving all background therapy at target doses, which is also not practical. So this traditional sequencing is probably wrong. Next. So there is a proposal for rapid initiation of first line of FREF therapy within 4 weeks. So at the end of 4 weeks, the patient should be on all 4 molecules. Next. In fact, you can start all of them in hospital. When a patient is admitted with acute heart failure, in hospital initiation of quadruple medical therapy has been now recommended. Next. At least at a smaller dose. So small doses of all 4 foundational therapies is better than up titrating 1 or 2 classes to maximum doses before adding additional therapies. Next. And that has come into the guideline. This is 2022 guideline, which says in the lower part, you can see that in patients with FREF, titration and optimization of guideline-directed medications as frequently as every 1 or 2 weeks, depending on the patient's symptoms, etc. Next. But even this is arbitrary. There is no real evidence to tell us how to up-titrate, how to initiate, how to up-titrate these medicines. Recently, luckily, just last a month ago, this trial has come and it's a beautiful study. It's called STRONG-HF. In STRONG-HF, what they did was the usual care is to start initially, then call patient after 2 weeks, maybe another 2 weeks. So maybe at the end of 4 weeks or 6 weeks, the patient should be on most of the medications, all 4 medications. The other arm you can see here is a high intensity care. You start half optimal dose before discharge. Call the patient at the end of 1 week, see for whatever clinical things, maybe creatinine, electrolytes, increase it. By the end of 2 weeks, full optimal GDMT dosages. So this is a trial, this is a CRT, this is a randomized clinical study. And this was done on 1800 patients. Next, just published, I think, in Lancet last month. And at the end of 6 months, it was shown that there is a significant reduction in mortality as well as rehospitalization, with a p-value of 0.0034. I mean, the trial was actually stopped because of one best benefits that are seen in patients, and it was thought unethical to continue the trial. So now I think we have guideline. It hasn't come in guideline as yet, but at least evidence to tell us that we should start all 4 molecules while the patient is in hospital at a lower dose, call patient after 1 week, see the patient, increase the dosages. By 2 weeks, you should increase all 4 if possible to target dosages. This is the best way to treat our patients of heart failure. Next. You can see here that in the brown is how they are up titrated, and most of the patients receive, 80% of the patients receive all 4 to target doses. On the other hand, in the usual care, the patients don't receive optimal dosages at all, less than 50, around 50%. Next. Similar thing here, that more than 80% of high intensity care were given half to full doses of GDMT. The blue one, actually, in the initial phase at least, is very, very poor. Next. So to summarize, world heart failure burden is rising rapidly. Fortunately, multiple medicines are now available, having robust data. There are 4 molecules which form the foundational therapy, called as Fabulous 4, for heart failure. And for them, early simultaneous initiation and rapid up titration to target levels is the way forward. Thank you.
Thank you, sir. It was really well elaborated, and we could at least know that the potassium level should be less than 5, isn't it?
Should be less.
And that ejection fracture should be more than 30.
No, EGFR.
EGFR, yes.
EGFR, because nobody talks about creatinine values nowadays. We talk about EGFR. So ideally, EGFR should be more than 30. We can go down to 20 also, and SGLT2 inhibitor can be given up to 20. So that is a safe medicine. Beta blockers, of course, can be given at any level of CKD.
Yeah. Okay. Thank you,
so
sir.
I think it is just common sense and just 3-4 parameters that you have to check and keep increasing the dosages. But the important message is start early and rapidly up titrate the dosages to target levels. That is the main message that I want to give.
Yes. Thank you, sir. Thank you very much, sir. Sir, our President Madam is little, I think she's busy with the patient. So I would like to thank you, sir. And
my pleasure.
Yes, sir. Thank you very much, sir, from IMA Pune. Now we'll go to the next lecture. Dr. Hemant Kulkarni, are you there? Good afternoon, sir. Dr. Hemant Kulkarni. Can I start with your introduction?
Yes, ma'am.
Yes, sir. Sir, can I start with your introduction?
Yes, ma'am.
Yes. Dr. Hemant Kulkarni has joined. His topic is minimizing the advancement of heart disease with dyslipidemia and CAD management. I'll introduce sir. Sir is a practicing physician, consultant physician, general physician, and general practitioner. About 17 years of experience. He's practicing now at Pimpri Chinchwad area. He's got a MD General Medicine from Davangere in 2005, and he has worked in as a physician at Aditya Birla Memorial Hospital. Apart from that, he has got many awards and recognitions, and mainly it is from practical diabetology from Denmark, then from Indian Society, Thyroid Society, then thyroid, then again he's got from Boston also. He's got diploma in cardiac emergencies in general practice, Boston University, and diploma in acid peptic disorders and irritable bowel syndrome from Boston University, and postgraduate program in different spectrum of acid related disorders from Boston University. So over to you, sir. Thank you and welcome to this webinar, sir. You can start, sir.
Okay, thank you, ma'am. Are my slides visible now?
Yes, sir. Yes, sir.
Okay, thank you very much. So good afternoon, everyone. I thank IMA Pune and AstraZeneca for giving me this opportunity. So today I'll be discussing a few points on dyslipidemia and its management over next 25 to 30 minutes. So let us begin with a case scenario here. Here we have a 42-year-old gentleman. He is a business executive. His body mass index is 25.1, slightly overweight. He is non-diabetic, normotensive. He has a strong family history of diabetes, both parents being diabetic. He is a smoker. His current blood test revealed higher lipid levels, LDL of 139 milligrams per deciliter, HDL 42 milligrams, triglycerides of 160 milligrams per deciliter. His lipid test done 6 months ago were also slightly higher than the present levels. He is currently on no medications, and he is only following lifestyle modifications. So here, what we should consider and what we should know, there are a few points we should be understanding here. So one is we should understand a risk of any patient with this particular parameters, or any individual. What is the risk of him entering into or having any cardiovascular disease in next decade or so? So we should first understand his risk. Then we should know whether the treating dyslipidemia or hyperlipidemia should be taken seriously, and it has to be treated earlier. And we should know what the guidelines recommend, and we should understand how fast we should act, and what are the target goals for treating dyslipidemia. And at the last, we should know which medicine to be given to any particular patient with dyslipidemia. Coming to some Indian data, which was published in 2014 in Indian Heart Journal, this suggests that small LDL cholesterol particles in Indian food are more atherogenic. In comparison with Europeans, cardiovascular deaths affects Indian almost a decade earlier. Cardiovascular diseases are the leading cause of death in India. Almost they comprise 28% of total deaths. In India, more than 50% of the cardiovascular deaths mortality occurring in individual below 50 years of age. This is very important data. And understanding the risk of our particular patient, we have a risk calculator called as ASVD risk calculator, which is easily available in Google platform. So it uses very simple parameters like age, sex, race, blood pressure, systolic blood pressure, cholesterol values, history of diabetes, smoking, and hypertension with or without aspirin or statins. So by putting the data of our patient, we could get a value of 6.3%. So 6.3% is considered as borderline risk. So any value below 5 is low risk. Between 5 to 7.5% is borderline risk. Between 7.5 to 20% is considered as intermediate risk, and more than 20% is considered as very high risk. So here our patient falls in 6.3% of risk, which is considered as borderline ASVD risk. So that means he has 6.3% chance of having, the 6 point, it indicates that the risk for having any cardiovascular disease in next 10 years for the particular patient. So here another study published in Lancet 2004, that is Interheart study, which says that dyslipidemia is the strongest contribution for cardiovascular risk in Indian population, almost contributing to 58.7%, followed by smoking and abdominal obesity. Coming to a few guidelines which have recommended over last 20 years, starting from 1988 with ATP1 guideline to the current ones, that is ESA and EAS guidelines in 2019. So in earlier, we had very goal levels were not very strict. In 1988, 130 was considered as a good cholesterol control target for high-risk patients. But over a period of years, the cutoff is very stringent, and now it is considered as 55 should be the goal for treating any patients with high risk of cardiovascular disease. So this is again, it shows what should be the goal for a particular patient with depending risk factor. So patient with low risk factors should be in them 116 or 115 should be considered as the goal of LDL cholesterol for the treatment. Then in patients with moderate risk, we have to keep LDL cholesterol below 100 milligrams. When patients with high risk factors should be considered for keeping LDL levels below 70 milligrams. And with patients with very high risk factors, we should target LDL cholesterols below 55 milligrams. So why we should try to target this high risk patients, and why we should reduce the cholesterols to these particular goals which were suggested by ESC in 2019 is very important, because it reduces, that is 1 millimoles or 39 milligrams of LDL reduction by statin. It reduces major risk factors or major cardiovascular events by 21% in any individual. So it reduces major coronary events by 24%, coronary revascularization risk by 24%, risk of stroke by 15%, and any death related to vascular etiology by 12%, or any case mortality by 9%, and effects on any major vascular events by 21%. So thus, it reduces a risk of any major vascular events by 21% in total. So this was published in Lancet in 2015. So there is another data which shows that continued and effective reduction of cholesterol, LDL cholesterol decreases the risk of cardiovascular deaths or diseases by huge percentage or significantly. So by reducing LDL cholesterol by 1 millimoles per liter, that is 39 milligrams per deciliter, it reduces risk by 22% over 5 years, 28% by 10 years, and 54% by 40 years. Similarly, by reducing LDL cholesterol from the baseline to the baseline by 2 millimoles per liter or 76 milligrams per deciliter, it reduces risk by almost 40% over 5 years, almost 50% over 10 years, and almost 80% over 40 years. So this shows the significance of or importance of treating dyslipidemia or hyperlipidemia in any patient. So this is another important data published in European Heart Journal in 2016, wherein it shows that reduction of LDL cholesterol by 50% decreased the event rate by almost 57%. That is almost 60%. So this is very important and significant data to suggest that treating cholesterol is very important. And as we all know that statins have been used for decades, and they are recommended as 1A in 1A class. So that means they are recommended with highly recommended for treating any patients with hyperlipidemia. So coming to a few comparison between atorvastatin and rosuvastatin, both of them have been used extensively in Indian population. So rosuvastatin is hydrophilic. It is not metabolized by CYP450. It is cleared by kidneys as well as liver. It has a half-life of 20 hours, and food has no impact on its bioavailability. That means it can be taken either with food or without food, doesn't matter. Whereas atorvastatin is lipophilic. It is metabolized by CYP3A4 enzyme. It is cleared mainly by liver. It has half-life of 11 to 30 hours, and it has some issue with food intake. Food reduces its bioavailability by almost 13%. So that means it is better to be used on empty stomach. Coming to some recommendations by Jupiter trial, which was published in 2008 in NEJM, so which showed that rosuvastatin reduced LDL cholesterol by almost 50% after its use over a year of time. So it showed that rosuvastatin treatment reduced cardiovascular event risk by 44% and cardiovascular mortality by 20%, which are very important and significant data. So here it showed that risk of MI, stroke, revascularization, cardiovascular reduced by 44%. Coming to something related with sympathetic stimulus, sympathetic system, sympathetic hyperstimulation or stimulation. So in previous talk, Dr. Sate highlighted the importance of heart rate, and heart rate is, we all know that, directly related with sympathetic stimulation. So coming to some data regarding Indian population, 9 out of 10 Indian people say that they are suffering from stress compared to global average of 86%. 3 out of 4 are not willing to talk about stress with medical professionals. 1 out of 2 Indians feel that they do not spend sufficient time for social activities with family, friends, or they enjoy their hobbies. 1 out of 2 Indians are not confident of taking care of their family's financial needs. 2 out of 5 professionals are experiencing increased stress or anxiety due to COVID-19. Of course, COVID has gone now. So this shows that most of the Indian population, especially adult population, are stressed by means some other means. So this is a very important data which shows that 62% of Indian hypertensives have sympathetic overactivity. So of late we see very young hypertensives. Most probably sympathetic overactivity plays a major role here. So we know how the physiology of sympathetic overactivity. I will not go in detail about this, but in nutshell, sympathetic overactivity causes hypertension, insulin resistance, and some or obesity related problems. So in all of them can cause increased coronary events, sudden cardiac deaths, and heart failure. Smoking is a very important risk factor for cardiovascular disease. It can stimulate sympathetic nervous system because we all know that nicotine contained in the smoking is dangerous. It causes major cardiovascular events as well as cancer. So nicotine stimulates sympathetic ganglia, and it makes them to release noradrenaline, which in turn has got very bad effects on the arteries. So smoking is associated with 2 to 3-fold increase in noradrenaline levels in the blood. Patients who continue to experience one or more symptoms every day are at a higher risk of cardiovascular mortality risk. And as Dr. Sate said, the elevated heart rate significantly increases the risk of mortality in patients with coronary artery disease and heart failure. So beta blockers, we all know for decades they have been used for treating hypertension, especially in patients with with increased heart rate and patients with heart failure. So they are recommended as class 1A level drugs for treating patients with high heart rate plus hypertension and in patients with heart failure. So beta blockers, basically they reduce sympathetic stimulation, reduce heart rate and cardiac contractility, and thus they reduce myocardial oxygen demand. So in short, it gives rest to the heart. So metoprolol, which is commonly used beta blocker over few decades, it reduces heart rate by 14.5 beats per minute. So it is rapidly and completely absorbed throughout the GI tract, including the distal GI system. Half-life is about 3 to 4 hours. Oxygen is to liver. No accumulation of drug is noticed in advanced CKD patients. No active metabolites are seen with this molecule. This is another important data published in JAMA in 1988, wherein it showed that metoprolol reduces the risk of all cardiac deaths and sudden cardiac death by a significant proportion. All cause death is reduced by 22%, and risk of sudden cardiac death is reduced by 30%. So, at a glance, in summary, dyslipidemia is a major risk factor for cardiovascular disease, which are one of the commonest causes of death worldwide, especially in India. Risk of cardiovascular death is higher in Indian population compared to West. The lower, the better. Severe event risk reduces with each reduction in LDL levels. Guidelines recommend setting of LDL goals for patients with primary prevention and use of statin as first line of therapy for to reach the goals to set the reduce specific risk levels. Rosuvastatin helps reduce LDL by 50% and risk of cardiovascular event by 44%. Compared to innovator statins, the probability of suffering a CVE for generics was higher on an average by 31%. Sympathetic overactivity is elevated in patients with diabetes, obesity, smoking, and stress. Elevated heart rate increases the risk of cardiovascular mortal deaths in patients less than 55 years by almost 2 times. Metoprolol helps to reduce sympathetic overactivity by reducing heart rate by 14 beats per minute, sudden cardiac deaths by 30%, and all-cause mortality by 22% in patients with coronary artery disease. Metoprolol with MUPS ZOK technology has prolonged release formulation and provides 24 hours duration of action, with its absorption being unaffected by food intake, pH of body fluids, and intestinal motility. Thank you very much.
Thank you, sir. Thank you for such a nice lecture. And with dyslipidemia, I think many of our patients are getting dyslipidemia because of their diet and exercise, lack of exercise, and with the food which they are eating outside, that is the fast food. So really, it's a dyslipidemia. It's very, I think it has become very common. Like all other like fever and all, dyslipidemia. Everyone, if you ask, they will tell you that their lipids are increased.
Correct.
So it was a very nice lecture, sir. So on behalf of our IMA Pune, Dr. Meenakshi Deshpande, madam. Yeah, I think she must be seeing the patients. So, sir, I will myself only. I am Dr. Alka Ksirsagar. I am a Pune secretary. I will felicitate you with our IMA Pune Uparna, and this is a token of appreciation.
Thank
so,
you.
Anytime to IMA Pune. Okay, you are always welcome.
Sure, ma'am. Thank you very much, ma'am.
Okay, sir. Thank you, sir. Thank you, sir.
Yeah.
Now we will go to the third lecture by Dr. Anuja Mule, madam. She's there. Yeah. She will be speaking on lowering risk of stent thrombosis, learning from a case. So I will introduce madam. Madam, welcome and good afternoon and welcome. She's the MBBS and MD from Pune University, and she has done DNB cardiology at National Board of Examination from NM Wadia Institute of Cardiology in August 2010. She's got an experience of more than 12 years, and she is working at present at Wadia Institute of Cardiology, Ruby Hall Clinic, Assistant Professor in Bharati Vidyapit and Hospitals, Pune, Mai Mangeshkar Hospital, and Dinanath Mangeshkar Hospitals. She is an associate fellow society of for cardiac angiography and interventions, and she is a secretary of Cardiology Society of Pune. She was other in 2013 and 14, and Indian Society of Electrocardiology. So, what do you, madam?
Thank you so much, Sada ma'am. So today I'm going to be talking about stent thrombosis. I hope you can see my screen.
Yes, madam.
So let us start straight away with a clinical case presentation. This is something that unfortunately sometimes we get to see in our clinical practice. The less we see this, the better. But unfortunately, we do see some patients like this, and hence we should know how to manage them. So basically, this is a 56-year-old gentleman who's a diabetic. He had suffered from an acute myocardial infarction. He's a smoker. His ECG showed ST elevation in V1 to V3. So it was a anteroseptal myocardial infarction. An angiogram was done which showed a totally obstructed left anterior descending coronary artery, which is the main branch of the left-sided coronary artery. So
Madam, your slides are not moving.
They will move. Is this okay?
This is the first slide only.
This is the first slide, yes. Yeah, okay. So when we did an angiogram, we saw a totally obstructed left anterior descending artery, which is the main branch of the left-sided coronary artery. So this artery basically supplies up to about 45 to 50% of the left ventricle, that is the majority portion of the myocardium. So he was taken up for a primary angioplasty with a loading dose of aspirin 300 milligrams and ticagrelor 180 milligrams. He underwent a successful primary angioplasty with two drug-eluting stents in the left anterior descending artery. So on discharge, along with other medications, he was put on ticagrelor 90 milligrams twice a day and aspirin 75 milligrams once a day. This is a routine protocol. So far, so good. We have done everything correctly. Nothing wrong with the patient. Happily, the patient has gone home. 3 months later, the patient comes for a follow-up. Then we thought that ticagrelor, the patient has had enough of a financial burden and also good antiplatelet agents. So now ticagrelor was switched to clopidogrel. So with a maintenance dose of 75 milligrams, a loading was not done. And so all these I am mentioning because these are important points. And at 3 months at follow-up, patient was shifted to clopidogrel without a loading dose to 75 milligrams daily. Within a week, the patient comes back with chest pain and a similar picture to a myocardial infarction. ECG was done. ECG showed ST elevation in V1 to V5. So now there is a full-blown anterior wall infarction. I hope you can see the ECG. So in the ECG, you can see this is an anterior wall infarction with right bundle branch block. So it's
madam, we can't see the slides. At least on the
IMA.
No, madam. The slides are not moving.
Not moving.
Should I share the slides, ma'am?
Okay.
Just a sec.
I thought you were just discussing the case, but when you said about the ECG, I couldn't see.
Can you see the screen now?
Now it is visible, ma'am.
Yes.
Visible?
Perfect.
Yes.
Make full screen just, ma'am.
Yeah, I just stopped it and restarted it, nevertheless. Yeah, so this was the ECG when the patient comes back after a week with a full-blown anterior wall infarction and a right bundle branch block. As you can see, there is a R wave in V1 to V6 almost, and there is a massive ST elevation starting from here to V4, V5. So this is a full-blown anterior wall myocardial infarction. So this ECG is suggestive that the LAD, which is the left anterior descending artery, has quite a proximal occlusion. So this is a picture of the angiogram. As you can see, the white arrow pointing here. Is this visible now?
Yes, ma'am. Screen is visible. Absolutely.
Yeah, okay, just confirming. So as you can see, this white pointing arrow, the LAD is totally cut off. So this is the left main coronary artery, this is the circumflex artery, and this is the left anterior descending. So the left anterior descending, as soon as it starts, it is totally cut off, which means that there is complete stent thrombosis in this artery. So there is a extensive thrombotic total occlusion of the LAD. So this stent thrombosis has occurred within a week.
Again, it is stuck to the ECG only.
Again, it has come to ECG.
Yeah, it is stuck to the ECG. Please, it's the fourth only
Can
slide.
you share the slides if you have them?
Sure, ma'am. I will
Just try once
share
again.
it.
If it happens, happens.
Yeah.
Yeah, they are not moving. Yeah.
Okay, now it is not moving on my side also.
Oh,
I will just share the slide if you want, ma'am.
yeah.
Now,
Now,
can you see the angio?
yes, now it is visible. Yes.
Okay. Is this visible now?
Yes,
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 ma'am.
madam. Very much visible.
Okay. So this is the angiogram with the white arrow, which shows a totally occluded LED. And now this is the angioplasty, which was done, and then the flowing LED. Can you see that now?
Yes, ma'am. Yes.
Okay, so yeah. So a balloon angioplasty was done along with administration of tirofiban and all the remaining drugs like nicorandil and nitrocontin and all the works. And a final angiogram showed a fully flowing LED with a TB3 flow with a normally flowing stents, that is. So this is what we wanted to achieve. But after de-escalation, there was a definite stent thrombosis which happened within 8 days. So this is known as stent thrombosis. And why should we prevent this? Obviously, because a patient with stent thrombosis is going to present to us with a myocardial infarction. There is going to be full-blown ST elevation. Patient could be hemodynamically unstable. So the outcome can be lethal, not just acutely, but even in long term. As you can see from the graph, the stent thrombosis is associated with a very higher risk of all cardiovascular events immediately, as well as at 30 days, as well as at 1 year. So one episode of stent thrombosis changes the complete mortality of this patient. So if you can see this graph, mortality increases, myocardial infarction increases, MACE, which is major adverse cardiac events, increase. Incidence of myocardial infarction increases at 1 year also, and at the MACE increases at 1 year also. The risk of one more event happening is almost to the fold of 70 times, or another myocardial infarction occurring is almost the fold of 20 times when one patient comes to us with a stent thrombosis. So that is why preventing stent thrombosis has to be a major priority. I hope my slides are moving now. So
Yes, ma'am.
Yes, moving.
So this is why we need to prevent stent thrombosis. So as I just said, it has a significant impact on mortality, both in immediate as well as long term. So the stent thrombosis is associated immediately with a 4 times higher mortality, and this mortality rate persists up to 5 years post PCI. So overall, the patient becomes a very high risk patient. It is almost like a ticking time bomb when a patient presents once with a stent thrombosis. And hence, preventing and treating stent thrombosis becomes a very high priority. Now, my slide is also stuck. Yeah. So this is just basically showing that the events are going to increase. These are the types of stent thrombosis depending upon when the stent thrombosis presents to us. So this is acute. Before that is hyperacute. Hyperacute means within the first 24 hours. Acute means in the first 48 hours. Subacute is up to 7 days. Late is up to 1 year, and very late is beyond 1 year. So this is the types of stent thrombosis classified according to the timing that when it occurs. Now, why does the stent thrombosis occur? There are multiple factors which can be possible and which can be contributory to this stent thrombosis. So now we have divided these into patient factors, procedural factors, factors of the lesion, and because of the stent. So patient factors means what? First and foremost, whether the patient underwent a primary angioplasty or he underwent an angioplasty for a stable disease. Primary angioplasty obviously is a thrombogenic milieu. It's a thrombotic milieu, and hence the incidence of stent thrombosis is definitely higher than versus a patient of chronic stable angina. If the patient has stopped DAPT, that is dual antiplatelet therapy, so compliance issues. Third and most important is clopidogrel non-responsiveness, which I will be talking about. Patients with lower ejection fractions, smokers, diabetics, and patients with known malignancy because it is a hypercoagulable state. All these are risk factors which contribute to stent thrombosis. During the procedure, if the stent is by for whatever reason underexpanded, so be it there, sometimes there can be calcium, sometimes there can be thrombus, there can be residual edge dissection, there can be incomplete apposition of the stent to the artery wall. These are procedural hitches and they can also be contributory to the stent thrombosis, incidence of stent thrombosis. Now, certain lesions are more prone to stent thrombosis than others. So if suppose there is a big artery which is bifurcating, like for example, the left main bifurcating into the left anterior descending, and that is where you have stented, that lesion becomes a higher risk than a regular stenting. So bifurcation lesions, heavily calcified lesions, bypass graft lesions, and in a person in which you are already treating in-stent restenosis. All these lesion factors can also contribute to stent thrombosis. And now mechanical things like two stents overlapping each other, or long stents, or a stent getting fractured, or the patient being sensitive or reactive to the drug which is used in a drug-eluting stent. So there are so many factors which go on to contribute in a stent thrombosis person. So the possible factors we need to identify, we need to prevent, and during and after and before the procedure, we need to be more careful, anticipating all these factors. So coming back to our case, why did he get stent thrombosis? Now, when he was tested, the patient was found to be a non-responder to clopidogrel. So the CYP2 receptor had a reduced function in our patient. So this is responsible for patients not responding to clopidogrel, and this is quite common. We will see how common. Additionally, he was a smoker, he was a diabetic. The drug was switched to clopidogrel without loading doses. So effectively, we shifted the patient back to ticagrelor 90 milligrams twice a day. And after about 3 or 4 days, the patient was discharged. Now, how common is this clopidogrel resistance? Now, globally, throughout the world, it has been studied that up to 44% of the population, so it's almost as good as 50% of the population, might have some amount of clopidogrel resistance. Even in the Indian population, 1 in 3 patients in a particular study from Delhi have been found to be clopidogrel resistant or poor responders to clopidogrel. And despite a higher dose of clopidogrel, even if you use 75 milligrams twice a day or 150 milligrams once a day, even that does not help to compensate the resistance. This was studied in the Gravitas trial, which was published in AMA. And even a higher dose will not overcome clopidogrel resistance. So that is why we have newer drugs like prasugrel or ticagrelor. Now, the benefits of each we will see later on. But we need to keep in mind from this that clopidogrel resistance does exist, and that is why we need to have options other than these drugs. So to understand how clopidogrel works, we need to know what happens when the thrombosis actually occurs. When there is thrombosis, be it a stent thrombosis or a myocardial infarction, basically what is involved is a platelet plug. This is a platelet plug. And this platelet plug contains immature platelets. Now these platelets are reticulated, they are spiky platelets. So they are more sticky, they are more reactive, and hence they are involved in the stent thrombosis or even in thrombus in any myocardial infarction. So these are the activated or reticulated platelets which are new and immature. So as you can see in a healthy subject, if this is the number of immature platelets, in a person with a full-blown myocardial infarction, this is the amount of active platelets that are present. And these are the platelets which are responsible for stent thrombosis. Now, what is these thienopyridines? Thienopyridines is basically clopidogrel and prasugrel. CPTP, which is cyclopentatriazolopyrimidine, is ticagrelor. These are the antiplatelet agents which are used in the treatment of acute as well as maintenance of myocardial infarction. So these are the drugs which we are going to study, which we are going to read about, And how do these work? So basically they are antiplatelet agents. So they bind either reversibly or irreversibly to the platelets and inactivate them. That is the easiest explanation. So what the thienopyridines do, that is what does clopidogrel do? Basically clopidogrel clopidogrel binds irreversibly with the platelets which are already existing in the body. The difference between the CPTP drugs, which is ticagrelor, is that it is a reversibly binding agent. As we all know, clopidogrel is used once daily, ticagrelor is used twice daily. So how these things matter, I am just talking about in the next slide. So what we need to do is, sorry, my slide just stuck once again. So what we need to do in these cases is basically we need to inhibit the platelet reactivity, and hence so now platelets are continuously being formed in our body. With a single daily dosage, it may or may not help. With a bi-daily dosing, maybe we are at an advantage of inhibiting more number of immature platelets. So as you can see, an increased platelet turnover is seen in patients with STEMI and acute coronary syndrome. So also with diabetics. So in a single daily dosing, if these increased reactive platelets are bound only once during the day, and that too irreversibly, so the drug is not getting released from the platelets and inhibiting, it is not free to inhibit the next dose of platelets which is coming in. So that is a disadvantage with once a day dosing with prasugrel and clopidogrel. Whereas that advantage we find with ticagrelor, because one, the platelets are bound with reversibly with it, and the new platelets, there can be a redistribution of the drug. So the new platelets which come, they are again bound with it and inhibited by the second dose of ticagrelor, which will come in after the 12 hours. So after an initial dose, first inhibition takes place. Administration of the second dose will further inhibit these drugs, and that is how there will be a greater inhibition of platelets. So as you can see, despite the increased platelet turnover, which is seen in diabetic patients or which is seen in stent thrombosis or in acute coronary syndromes, ticagrelor is still going to serve the purpose because of twice daily dosages. So the effective dose and the exposure to platelets is going to be higher. As you can see the graph on the right side, the clopidogrel peak and the dosing, and the prasugrel peak and the effective dose, they peak early. Because of the irreversible binding, the effect continues. But what about the new platelets that are coming in? This is going to be, this is the key, this is the crux which is going to bind the newer platelets which are being formed continuously. So as you can see, the platelet inhibition is going to be uniform over the entire 24 hours. Does this only work as an advantage? No, this has a major disadvantage. And what is that? If the patient forgets this dose of ticagrelor, the therapeutic dose is going to fall. And hence, even if a patient misses a single dose of ticagrelor, he can come back with a stent thrombosis. So this is a double-edged sword. With potency also comes shorter duration of life, and hence every dose is important. So we have a major benefit, which is uniform inhibition of platelets, but a major, I will not call it a disadvantage, but a problem that single dose also needs to be not missed by the patient. So this is how ticagrelor is superior to the original thienopyridines and which is the clopidogrel and the prasugrel. So all the platelets, be it active or inactive, that is the reticulated platelets as well as non-reticulated, everyone is going to be inhibited by ticagrelor as comparison to prasugrel, like we have seen with clopidogrel. So we have just seen this, that once daily dosing is insufficient when there is a high platelet turnover, especially in diabetic patients and patients with ACS. So in those patients, there is definitely going to be a benefit which is more with ticagrelor than with clopidogrel or prasugrel. This we all know that ticagrelor reversibly binds, it is active without metabolism, and the mean half-life is 7 hours. Whereas clopidogrel and prasugrel are thienopyridines, there is irreversible binding and there is a prodrug which is converted into an active metabolite which continues the range of action for 24 hours. So in this situation then, which is the right correct oral antiplatelet agent? As we have just seen, this is a diabetic patient, there is stent thrombosis, so there is acute coronary event. Hence, ticagrelor is going to be definitely superior to clopidogrel and prasugrel in showing us benefit. Now, does this translate to mortality or is it just a temporary transient benefit? No. As you can see here, this is a mortality modifying agent. So there is a definite mortality benefit with ticagrelor to the extent of 21% reduction in cardiovascular death, a 16% reduction in myocardial infarction, and a 22% reduction in all-cause mortality. So there is a significant mortality benefit. You can see that with prasugrel also there is a significant mortality benefit. Why the all-cause death is not significant is because prasugrel also increases bleeding side effects, which is not seen with ticagrelor. Ticagrelor is safe as well as effective as compared to clopidogrel as with prasugrel. So this is just to show the Triton-TRIMI trial, which was done to compare clopidogrel and prasugrel. So as I just mentioned, prasugrel has been shown to increase the risk of bleeding over clopidogrel, and hence that nullifies the all-cause mortality. Also, the dose adjustment of prasugrel, which is needed in patients who weigh less than 60 kgs or who are more than 75 years of age, they need to get half the dose of prasugrel, that is 5 milligrams instead of 10. Also, prasugrel is contraindicated in strokes and TIAs and a post-surgery patient within the first 7 days of surgery. So these are the disadvantages of prasugrel, although it is more patent definitely than clopidogrel, and there are very less chances of resistance seen with prasugrel, but the bleeding incidence is higher. Now coming to the two major trials of ticagrelor, which were Plato and Pegasus-TIMI. What is the difference between these two trials is basically the old trial only studied patients with acute coronary syndromes, and the Pegasus-TIMI studied patients with all kinds of coronary artery disease. All of them received ticagrelor 180 milligrams loading dose and aspirin followed by 90 milligrams twice daily. Pegasus-TIMI also studied 60 milligram daily dose of ticagrelor. So what happens with these drugs? Both these trials, if the patients received ticagrelor for 1 year and even beyond. And this was studied, which showed, obviously, as you can see, ticagrelor definitely showed a benefit in mortality. It showed a benefit in bleeding, which was comparable. So no major, extra major bleeding was seen. The bleeding side effect was comparable, so there was no disadvantage. And you can see the mortality benefit. The numbers we have already seen. So there is a definite reduction in cardiovascular death, myocardial infarction, need for invasive management, irrespective of whether this patient went for PCI, that is angioplasty, or bypass surgery or medical management. So irrespective of the arm of management of these patients, they received ticagrelor and they showed us benefit. And for how long? In both these trials, the ticagrelor was given for at least 1 year, in sometimes even more. Sometimes is what, sometimes means what now? Sometimes is basically all the patients who can tolerate dual antiplatelet therapy, which means aspirin and ticagrelor. Tolerate means what? For the 1 year that they take these dual antiplatelet agents, there is no increased risk of bleeding. They are not very elderly patients. They are not going to need any sort of major surgery. All these patients who can tolerate dual antiplatelet therapy need to be on dual antiplatelet therapy, and they need to be continued on it. So in the invasive arm, as you can see, there is a definite reduction in the risk of stent thrombosis to the tune of 36%. So this is very, very significant with ticagrelor as compared to Plato. The stent thrombosis reduction was also very significant to almost the tune of 50%, not just acute, but also subacute and late stent thrombosis. So in the stent, in the patients who underwent stenting, there was 0 stent thrombosis seen with ticagrelor, whereas 9% with clopidogrel. So there is a definite benefit, mortality as well as morbidity benefit with ticagrelor as compared to prasugrel. So if there was a 0% risk stent thrombosis, it means that there was a 100% risk reduction in stent thrombosis. That is what this slide that shows us, that there is a 100% risk reduction of stent thrombosis in the ticagrelor arm. Various other studies, which was real world evidence, have also shown us similar outcomes with ticagrelor. As you can see, this was a single center real world observational study. which included more than 10,000 patients. So this is a large study which shows us almost a 50% reduction in stent thrombosis as compared to clopidogrel. So ticagrelor is showing us benefits in randomized trials as well as in real world evidence. There is definite benefit, and there is an advantage of using this drug as compared to prasugrel or clopidogrel. As you can see here, the benefit continues for in the acute stage at 1 month, 2 months, 3 months, for a year, and even for up to 2 years. This benefit has been studied and observed that the benefit is extended to the same extent in patients with reduction in cardiovascular events. No major increase in bleeding events. So the fatal bleeding or non-fatal intracranial bleeding event was also lower with ticagrelor as compared to any other drug. And this is obviously along in combination with aspirin. Now, when was ticagrelor 60 used twice daily instead of 90 milligrams? So this was studied in the Pegasus-TIMI trial. So in these patients who are basically patients in the low bleeding risk, patients in the high bleeding risk who have more than 2 ischemic factors like maybe diabetes or multivessel disease or smoker, chronic kidney disease, all these high risk bleeding patients, they were given 60 milligrams of ticagrelor instead of 90. And they also showed a definite benefit up to 3 years with ticagrelor, even 60 as compared to 90. So all the patients with a higher risk also had so patients with more than 2 risk factors get the greatest benefit when ticagrelor in a reduced dose is used, because the bleeding risk does not increase in that proportion. So now choosing between, now there are multiple brands of ticagrelor which are available. Ticagrelor is a costly molecule. Let's face the truth. So it is 35 rupees per tablet. So that comes to 70 rupees during the day. So there are various molecules available in the market every day. Almost we see now we have also introduced ticagrelor around a year ago. Every company was coming with new ticagrelor molecules. What we need to look at when a person from the company comes to tell us about ticagrelor, this is equivalent to the original molecule. Equivalent means what? There can be pharmaceutical equivalence, means that the drug is in equal amounts in each of the tablet. Is that really important? Because the drug may be the same amount, but is it released in the same manner in the bloodstream? That is known as bioequivalence. So the blood concentration of the drug has to be achieved in the same manner by all the drugs, be it a generic drug, be it a private company drug, be it manufactured by the hospital or by us, doesn't matter. But this is what is important. And then it comes to the therapeutic equivalence. What does that mean? If 100 patients are given 1 molecule of ticagrelor A and 100 patients are given B, then the incidence of any event in those 2 must be the same. That is known as therapeutic equivalence. So when we look at any generic drug, be it ticagrelor or be it any antihypertensive agent or any other agent or an antibiotic, what we need to ask the company is, are you giving me bioequivalence or therapeutic equivalence in all the patients? That is what is most important, because that is going to affect the outcome of our patient. There are various brands available and there is a huge variation in bioavailability. So if the dose is less, which means the therapeutic effectivity is less, there is obviously going to be a risk of ischemic events. If it is more, there is going to be a risk of bleeding. So less or more, it is going to be the same thing. And why is there such a variation? Because it's a complex molecule. There are 64 ways of going wrong in ticagrelor, or rather 63 ways of going wrong, because of the 64th will be the right one. Because it's a 3-dimensional orientation with a structure having 6 chiral centers. So it is a very complex molecule, and hence it is important to achieve isomeric purity. A study was done in Kerala. If you can see this slide, this is a very funny slide, I find. The percentage purity of the drug, if you can see on the right side, is sometimes even more than 100%. This was an actual study done in 2020 in Kerala, and this is the kind of variation that was done. So the claimed amount is 75 milligrams. This was actually done for clopidogrel, and this was the purity that was achieved. So as you can see, this is absolutely funny. So you have 100% purity and 106% and 117%. This is ridiculous. The same amount of drug needs to be present in all the drugs. So this is the claim, 75. and what the patient is getting is absolutely nonsense. And it is going to affect not just the acute short-term effects, but the long-term mortality in terms of safety and efficacy. And hence, this is very important. So this is also a reason for stent thrombosis. When the generics of ticagrelor came in, there was suddenly an increase in stent thrombosis to the extent of 2 to 3 times. And why is because therapeutic equivalence was not being achieved. And hence we got a cluster of suddenly occurring acute and subacute stent thrombosis, which suddenly went away because everyone realized, no, there is something wrong in this generic brand. We need to go back to the original molecule. And when that happened again, now we are back to safety and we are back to efficacy. So that is why it is important. I do not say that everyone needs to take certain forms of company or whatever else, but purity and efficacy need to be achieved, especially in these molecules on which the life of the patient is going to depend. So basically with generics, we need to know if they are really pure, if they are really efficacious, and if they are really reducing the high platelet activity. So all these studies have been done with clopidogrel because clopidogrel has been there for many number of years. So this is just to give us an idea that when the generics are used as compared to the originals, there is a definite increase in complications. This was with clopidogrel. This has been studied in 2018. So the mortality, morbidity, everything increases. And finally, the onus is on us as treating physicians or treating cardiologists that we have to know that, or rather the patient is going to come and ask us why this is happening. I have been taking all my medicines regularly and still why this happens. This is the reason. And we don't want to be responsible for that. So all the evidence from the trials, from the real world, everything has been studied with the innovator ticagrelor, which all of us know that it is Brilinta. So I will not hide it anymore, but it is what it is. And the benefit has been seen with it, which has not been studied along with any generic ticagrelors. So currently, if we have to use generics, use a drug which has shown therapeutic equivalence, bioequivalence for our patients, because that is important to reduce mortality. Sorry. With this, I think I'm at the end of the presentation. Thank you. Yeah, that was actually my last slide, so we can go on to questions or if we have time.
Yes, thank you, madam. Your slides went off abruptly, so we were wondering whether there are slides, but then I could see that.
I was anyway at the last slide, so I stopped sharing them.
So see, everyone was so stuck up with your lecture. So no one would thought that Baba abhi slide khatam ho rahe hai. Thank you, madam. Thank you very much. Our patient madam has just arrived here now, so she'll be felicitating you. I will request my
Thank you for a very nice talk. Actually, I was listening throughout to your talk, and please come to IMA whenever possible.
Yes, I do. I do come, and I love to come there. Thank you so much.
This is a bouquet for you, and an IMA Uparna for you.
How nice. Thank you.
You can come and have it.
Oh, very sweet. This is in true Pune tradition.
Yes.
Thank you so much.
Thank you.
It is always a pleasure to talk in IMA.
Yeah, thank you, madam. So we'll be going for the fourth lecture. Dr. Shriram Godbole, sir. Yes, sir. Yes. Yes, sir. Good afternoon and welcome to this webinar, sir. Sir, your topic is treatment intensification with SGLT2 inhibitors and plus DPP4 inhibitors. So I'll be introducing, sir. Yeah, it's here. There is a MD Medicine and DNB Endocrinology from All India Institute of Medical Sciences, New Delhi. Sir is consultant endocrinologist at INSTRIDE, Pune, that is Institute for Treatment and Research in Diabetes and Endocrinology. And he's also a consultant at Jahangir Apollo Hospital, Pune. He's a co-author of Full Life with Diabetes and Madhumeha in Marathi. Sir has got Dr. S.N. Cooper Award Oration, Maharashtra Ophthalmology Society, Moscow, 2011. And Scientific Committee, ISICON, Pune, 2011. And Dr. Baliram Dubey Memorial Oration Annual Conference, IMA Nagpur, 2017. So over to Dr. Srirango Odbale, sir. Sir, you can start your talk now.
Thank you so much for that kind introduction and this opportunity to speak in front of our IMA members. I hope this slide can be seen in its presentation mode. I only hope it will move forward. Otherwise, somebody else will have to project it for me. As is written.
You can see the slides. Only thing is make it full screen, sir.
Yeah, make it full screen and you try moving the slides so we can make out there.
So I don't know why this is not coming in the full screen mode. Otherwise, if somebody else can project, is Mr.
Yes, sure, sir.
Okay.
Yes, sure, sir. Just a minute. Huh?
Yeah,
just a minute.
Just do that. So I'm going to basically discuss the combination of an SGLT2 inhibitor and a DPP4 inhibitor in the management of type 2 diabetes. And we'll focus on specifically dapagliflozin, saxagliptin in particular, though I will also be touching upon the general class of these two anti-diabetic agents, which have become so popular in recent years, especially when the patent for dapagliflozin has expired, and we can now use it in more and more number of our patients to give maximum benefit. So if you can project those slides. See, basically the human body is loaded with around 180 grams of glucose per day. That is the amount of glucose approximately that is filtered through the renal tubules, as you can see over there. But you know that virtually no glucose appears in the urine. And that is because there is a very effective reabsorption mechanisms of the glucose as it passes through the renal tubules. So 90% of the filtered glucose is reabsorbed by what are called as the SGLT2 receptors, and the remaining 10%, which moves forward, is reabsorbed by SGLT1 receptors. Now you have a set of drugs called the SGLT2 inhibitors, which are highly specific. They inhibit only the SGLT2, but not so much the SGLT1. And as a result, because 90% of the job is done by the SGLT2 inhibitors, therefore, since the reabsorption is inhibited, you now paradoxically have a greater glucose being passed through the renal tubules and into the urine. So when SGLT2 inhibitors were introduced, we saw them as drugs which dump the excess glucose in the blood of a type 2 diabetic person into the urine, with the result that you get about 70 grams of glucose coming out through the urine if you give a drug like, say, dapagliflozin. 70 grams of glucose amounts to about 280 calories. So the person is losing 280 calories per day through the urine, which is one very important mechanism for weight loss in this category of drugs. But SGLT2 inhibitors are far more complex mechanisms, as we have discovered over a period of time. But this is at the very minimum, the basic action of why SGLT2 inhibitors are used as anti-diabetic agents. Now, the beauty of these drugs that for their action, they don't need endogenous insulin. The person may be deficient, relatively speaking, to insulin, but yet SGLT2 inhibitors will continue to work. Now, how effective are these drugs in lowering the HbA1c? Now, every drug nowadays has to undergo a comprehensive drug development program, which you will see in the next slide. this drug, for example, the dapagliflozin, which we are going to focus today, has been studied as an add-on to metformin versus placebo plus metformin, or as an add-on to the very popular combination of metformin sulfonylureas as a background, or in combination with various other drugs, including, for example, a combination of sitagliptin and metformin, or even as an add-on to a background of insulin with or without other glucose-lowering therapy. And if you consider the baseline A1C as somewhere between, say, 7.9 to even up to 9.3 in these various studies, depending on the baseline A1C, you will get a very significant lowering of HbA1c in any of these groups with different background therapies. So by and large, with dapagliflozin on a background of various therapies, you're expected to get an HbA1c reduction of anywhere from -0.8 to even up to 2% in some of these studies. But by and large, you can say close to 1% A1C reduction is what is seen in most of these studies. So a very significant reduction in the A1C. Next slide. Now, if you look at weight, because this is one major advantage with SGLT2 inhibitors, they actually cause weight loss. So again, if you look at the weight loss seen in different studies with different background medications, you find that that's on an average about 3 to 3.5 kilograms of weight loss that is seen in these studies, which are by and large around 26 weeks or 52 weeks. And importantly, even on the background of insulin, which actually causes weight gain, you would still see weight loss occurring even in those patients who are using insulin. This is a big advantage of SGLT2 inhibitors. Next slide. Now, if you look at the amount of A1C reduction, that by and large would depend on your baseline HbA1c. So the higher the baseline HbA1c, as you can see when you move from left to right, you will see that the HbA1c reduction is greater the baseline A1c. So particularly when the HbA1c is more than 8.5 or 9, you will see very, very significant A1c reduction exceeding 1.3, 1.4%. But the other pleiotropic benefits of SGLT2 inhibitors, which is shown over here, are also very important. You get important reductions in the blood pressure, both systolic as well as diastolic. This is, of course, the placebo-induced reduction in the systolic and the diastolic blood pressure. But even if you minus the placebo effect, you will still approximately get a 3 to 4 millimeter mercury reduction in the systolic blood pressure when you use a molecule like dapagliflozin, and that's largely because sodium is excreted through the urine to a very large extent. Next slide. So dapagliflozin has multiple glycemic benefits. It also has multiple extra glycemic benefits. Now, nowadays, we are not just, we don't just look at the glycemic control, but we are also looking at how durable the control is. Does the good glycemic control with a particular drug remain the same with the passage of time, or does it start declining after some time? And these are a few studies which are comparing, for example, a drug like glimepiride, very commonly used. So if you compare, for example, a drug like dapagliflozin versus glimepiride, what you typically see is initially the sulfonylurea will work very robustly and even better than the dapagliflozin. But after some time, when you follow up this patient, you find that the HbA1c slowly starts rising, because very often glycemic control with sulfonylureas are not very durable. And after a period of time, actually, the HbA1c would relatively start rising, so that the net lowering of the A1c is not very impressive as you would have expected initially. On the other hand, a drug like dapagliflozin might be a little slow to show its initial glycemic lowering, but once it does that, by and large, this, which you can see in red over here, by and large, the glycemic control is sustained. And this is data that I'm showing over 4 years, which is pretty impressive data. Even the reduction in the blood pressure, this is also a sustained sort of reduction that you get. This blood pressure doesn't again go up. Now, if you say, for example, compare drugs like glimepiride and dapagliflozin, the difference in the HbA1c may not be too much at the end of, say, 4 years. But what is also equally important today is How you achieve the glycemic control? Do you achieve by giving the patient hypoglycemia, or do you achieve it without hypoglycemia? So a drug like dapagliflozin per se never causes hypoglycemia. And this is seen from the effect, even if you have a matching lowering of the A1C with glimepiride, this is done with 1/10 the incidence of hypoglycemia compared to glimepiride. So if you want a good glycemic lowering agent, which has sustained action proved with at least 4 years data, with minimum or no hypoglycemia, then you're looking at a drug like dapagliflozin. Next slide. Now, why do we need to intensify treatment? If a drug is so good, why can't we just continue with that drug indefinitely? The reason for this is that type 2 diabetes is a progressive disease, and as the disease becomes more and more chronic, insulin deficiency is the rule. Beta cells will continue to die, and therefore no drug is expected to work as effectively in the same doses as the duration of diabetes increases. And this is what we see in India. This is real world evidence, which is studied in more than 3,000 patients across India. And here the mean HbA1c at the baseline at the end of 4.5 years, you can see is a dismal 8.6%, and around 45% of patients are completely uncontrolled on metformin. And even if patients are on metformin and sulfonylureas, almost 1/3 of these patients have not met their targets. And actually in our country, at least as per this study, it takes about 4.5 years for the healthcare provider, for the doctor, to initiate a second line treatment after a first line treatment is failing. And this is the average BMI of Indian patients. We tend to think of Indians as thin. Well, they are thin fat Indians certainly, but there are also Indians with a very high BMI. So we have to get over this inertia of intensification of treatment. We have to think of, hit early and hit hard as far as type 2 diabetes is concerned. Next slide. So what we need in type 2 diabetes is not just a glucose-centric approach, but in addition to glycemic control, which is of course a basic thing in diabetes, we also need to tackle the problem of weight. We need to tackle comorbidities like hypertension if we want to prevent cardiovascular and renal morbidity and mortality. And of course, we should be doing all these things very safely with a very low risk of hypoglycemia, because that is going to improve the patient adherence to our therapy. Next slide. Now, what is the rationale for this combination of dapagliflozin that represents the SGLT2 inhibitor class and saxagliptin, which represents the DPP4 inhibitor or the gliptin class? What's the rationale? Next slide. Now, we know that type 2 diabetes is a very complex disease. It has at least 8 different pathophysiological defects. I'm not going to read all of them. I think we know them. You have insulin deficiency, you have insulin resistance, you have inappropriate glucagon secretion, you have inappropriate incretin effect, you have increased quantities of fatty acids being formed, which are highly metabolically active. You have, as I told you, excess of glucose being reabsorbed into the blood from the renal tubules. So a whole lot of pathophysiological defects. And naturally, when we want to combine different drugs, we want to combine drugs with complementary mechanisms of action, which can cover more and more of these pathophysiological defects. Next slide. Now, if you consider a combination of a DPP4 inhibitor and a GLP-1 or a SGLT2 inhibitor, you find that, can you go to the next slide? You will find that between the two classes of drugs, out of these 8 defects, which I just told you, the ominous octet as it is called, this combination is going to cover about 6 out of those 8 defects. And if you look at the 4 different parameters which I alluded to, the risk of hypoglycemia, and you compare these 2 classes of drugs, both these drugs have very low risk of hypoglycemia per se. If you look at weight, because that's a very important comorbidity to target, SGLT2 inhibitors cause weight loss, whereas the DPP4 inhibitors are weight neutral. On the other hand, popularly used drugs such as sulfonylureas or thiazolidinediones actually cause weight gain. The metformin could be classified as weight neutral. As far as CV safety is concerned, which is a big concern nowadays, both these classes of drugs, the DPP-4 inhibitors, SGLT2 inhibitors, have been proved to be cardio safe and in fact cardio beneficial as far as SGLT2 inhibitors are concerned. The same can't really be said of sulfonylureas. TZDs, yes, also cardio safe. And if you look at systolic blood pressure, it's only the SGLT2 inhibitors which actually reduce the blood pressure, with DPP-4 inhibitors and the other classes of drugs being neutral. So these two combinations of DPP-4 inhibitors, SGLT2 inhibitors will actually bring together or complement the mutual benefits of each other with regards to those four factors. Next slide. If you can just move forward. Can you move forward, Pankaj?
Pankaj? What is that?
If you can change the slides.
I will call him, sir.
I'll call him, sir.
Hello. Sir, we are changing.
Yeah. Now, I was talking about cardiovascular safety and benefits, and nowadays, you know, newer anti-diabetic drugs have to undergo a CV outcome trial, and this is the DECLARE-TIMI trial, the CV outcome trial with dapagliflozin, and one of the primary endpoints of this trial was a composite of hospitalization for heart failure or cardiovascular death. And here you see that dapagliflozin versus the placebo, and you can see that the two curves separate very early on, and you get a very significant relative risk reduction for the primary composite endpoint. How about safety? Very often some of us, you know, are concerned about safety of SGLT2 inhibitors, but if you look at this particular trial, you will find that whether you take treatment emergent serious adverse events or, you know, see events of interest like diabetic ketoacidosis, amputations, fracture, genital infections, you can see by and large, you can see that the difference between dapagliflozin and placebo is actually, there's hardly anything to choose between these two drugs. The red ones which stand out against dapagliflozin, as you would have imagined, genital infections a little more common compared to the placebo. You have to counsel the patient. Also, diabetic ketoacidosis, relatively speaking, a little more common than placebo, but absolutely speaking, the risk is minimal. So in general, the safety profile of dapagliflozin is extensive. It's very excellent. It's almost comparable to placebo if you remove the genital infection part of it. Next slide. Importantly, urinary tract infections are not more common with SGLT2 inhibitors or dapagliflozin compared to the placebo. Now, because of this, these findings in this study, the hospitalization for heart failure, dapagliflozin was the first anti-diabetic molecule or SGLT2 inhibitor to be used in a pure heart failure trial with reduced ejection fraction. And remember, 45% of course of these patients who were recruited in this trial were type 2 diabetics, but importantly 55% did not have diabetes. So this is a pure heart failure trial, heart failure with reduced ejection fraction. And what they found was, compared to the placebo, there was a 26% relative risk reduction in the same composite of cardiovascular death or worsening of heart failure. And in fact, the component of hospitalization for heart failure is what drives actually this composite. There's a 30% relative risk reduction for the hospitalization of heart failure. And again, in this trial, the safety of dapagliflozin was well established. So this is a consistent benefit, the benefit for heart failure, whether the person has diabetes, does not have diabetes, irrespective of the background heart failure therapy, irrespective of whether patients were on diuretics or not, irrespective of their NT-proBNP levels, the baseline LVEF or the eGFR, there is a reduced risk of both the first and recurrent hospitalization for heart failure events, and also importantly, reduction in all-cause mortality and improvement in the quality of life of these patients. So, and actually, this reduced risk is seen as early as, day 22 of the trial. So very early on, after you start using dapagliflozin, your patients with heart failure with reduced ejection fraction will report improvement in their complaints. Next slide. Virendra, can you change the slides? Now, I already told you this, that irrespective of whether patients in this study had diabetes or not, it didn't matter. The heart failure was improved across the board. Now, but we are talking of the combination of dapagliflozin and saxagliptin. Yeah, continue ahead with the slides, please. Now, remember, saxagliptin is a very useful gliptin, but the question is whether adding saxagliptin to dapagliflozin, will it address our dual concerns of glycemic control and cardiorenal risk reduction? So next slide. Now, if you look at the combination and you look at the various baseline A1C groups. So on the one hand, I'm showing a combination of Saxa plus DAPA plus metformin. This is the triple combination versus only Saxa plus metformin versus only DAPA plus metformin. So if you look at the triple combination, the reductions in the HbA1c will be greater with the DAPA-Saxa combination rather than using each individual drug separately. So combining two drugs will always give you incremental glycemic lowering benefits, irrespective of your baseline A1C, whether it is less than 8, 8 to 9, or more than 9, the glycemic benefit is better using a combination. Next slide. Now, this is again a meta-analysis of some 58 RCTs involving more than 31,000 patients. And again, as you see over here, this is comparing various gliptins, the sitagliptin, vildagliptin, alo, and linagliptin. If you look at saxagliptin, using as a monotherapy, I think all of them are virtually the same. But if you use saxagliptin as a combination, then even between the gliptins, there's a slight benefit in favor of saxagliptin. You can see the figure over here for combination therapy, a very powerful reduction when saxagliptin is used in combination. Next slide. Now, this is also important. Microalbuminuria is a marker not just of kidney disease, but actually a marker of endothelial dysfunction and hence of cardiovascular disease. Now, it has been shown in various studies that if you compare saxagliptin with standard anti-diabetic drugs, the saxagliptin would reverse the microalbuminuria to normal in about 31% of patients. So nearly 1/3 of patients, type 2 diabetics who have microalbuminuria, can expect a reversal just by using saxagliptin as per this study. Next slide. If you could change the slide, Virendra. Yeah. Again, looking at safety, actually, see, in SGLT2 inhibitor use, we are concerned with genital mycotic infections. So for example, in the DAPA metformin group, you get 5.9% of patients getting genital mycotic infections. If you use only saxagliptin metformin, the percentage comes down dramatically, only 0.9%. But look at this, you're using saxagliptin plus dapagliflozin plus metformin. You would have expected that because dapagliflozin is here, then this percent should be as high as the dapagliflozin metformin arm. But that's not so. It comes down by almost half. So actually, if you add a gliptin to a gliflozin or an SGLT2 inhibitors, there's a lot of evidence now that actually the risk of genital mycotic infection actually goes down because yeast infections become lesser when you add a gliptin to an SGLT2 inhibitor. Next slide. Now, the one reason why saxagliptin received a setback was that in its cardiovascular outcome trial, the data showed a slight increase in hospitalization for heart failure. So when people start using saxagliptin, just move forward. What they are concerned about with saxagliptin is heart failure. I already showed you dapagliflozin actually causes a very significant reduction in the risk of hospitalization for heart failure. Now, when you use saxagliptin, does that benefit get negated, or does actually saxagliptin increase the risk of heart failure? Let's move forward. Now, if you look at that particular trial where I showed that the heart failure increased with saxagliptin compared to the placebo, if you look at the hazard ratio as the trial progressed, you find that actually the hazard ratio reduced. If you look at these figures for HR, the hazard ratio, they actually reduced as the patients were continued to be exposed to the medication. Actually, the trial ended in 2 years, so there was no enough time to see how much it actually reduced. But you might expect as the drug exposure increases, actually the hazard ratio of heart failure reduces. Now, there is a very reassuring data from Korea. If you can just move the slide forward, this is a real world evidence based on insurance claims, and they are comparing saxagliptin to other DPP-4 inhibitors using sitagliptin as a standard. If you can just move the slide further, if you look at the entire data, which involved about 534,000 patients, and sitagliptin was used as a comparator against which all the other DPP-4 inhibitors were compared, you find that actually those who were using saxagliptin actually showed a reduced cardiovascular risk compared to those who were using sitagliptin. Now, this is again a very important study, I think, from the point of view of saxagliptin, where you are actually recruiting patients over 24 weeks who have some sort of risk for heart failure by one of these three criteria, either an ejection fraction of less than or equal to 45 within the last 6 months, elevated NT-proBNP, or an optimized 6-label standard treatment for HFrEF. And you are randomizing these patients to saxagliptin, sitagliptin, and placebo, with the primary endpoint being changed from baseline in the left ventricular end diastolic volume index, which is actually a surrogate for heart failure, with various other secondary endpoints. And this trial was conducted in 10 countries across 75 sites, including those in the Asian region. Next slide. Now, if you look at the primary analysis comparing saxagliptin arm versus the placebo arm, actually, this is not statistically significant, but actually there is no sort of safety signal that is adverse over here. So if at all, numerically speaking, the LV-EDV index was better in the saxagliptin arm compared to the placebo arm. So this is a very reassuring study when we start using saxagliptin. Next slide. Again, the secondary analysis for various other parameters is very, again, reassuring. You can see the p-value is not significantly different for both these arms. So actually, in this particular, sort of a supplementary evidence, saxagliptin does not seem to have so much of a risk of heart failure as we often fear it to be. So actually, if you combine saxagliptin and dapagliflozin, you can still expect a very good glycemic lowering, with, of course, virtually zero hypoglycemic risk, unless, of course, the person is on a secretagogue or an insulin, with, in fact, possibly a reduced risk of genital mycotic infections, with possibly, I would say, no very great risk of heart failure or hospitalization for heart failure, though, of course, it is prudent to exclude patients who have had a previous history of heart failure or who are already on heart failure lowering agents. One might be a little prudent when you introduce saxagliptin, but otherwise, for the vast majority of our patients, I think this combination of dapagliflozin and saxagliptin seems to be very efficacious and relatively safe. I thank you all for your patient listening. It's always a pleasure to speak for the IMA. Thank you so much.
Thank you, sir. It was a real nice lecture, sir, and you have already elaborated everything very efficiently, and as per your experience, we are just nothing in front of you, but it was really a wonder. And saxagliptin and the other drug dapagliflozin, so that is in combination with metformin, is quite good. whatever you are told, I think
Are there any questions in the chat box?
There are two. I think they are saying thank you. No question in the chat box. She's saying thank you, and the other one, excellent presentation.
Okay. Yes. So the presentation was to the mark. I think there are no difficulties or no questions.
Yeah.
So thank you, Dr. Sriram Godbole.
I request Dr. Meenakshi Deshpande, Madam, our President, to felicitate you, sir.
This is our IMA Pune Uparna for you, sir.
Thank you so much.
And
what an honor. Thank you.
Yes.
Great pleasure. Pleasure is all mine. Thank you.
I'll be, thank you, sir. I'll be going to the next speaker, Dr. A.G. Unnikrishnan. His topic is non-diabetic CKD. Is there hope on the horizon with dapagliflozin? I'll introduce you, sir. Welcome, sir, and good afternoon, sir. Dr. A.G. Unnikrishnan is an endocrinologist and CEO of Kelaram Diabetes Institute, Pune, a leading diabetes institute in India. He heads clinical care, research, education, and also oversees philanthropic rural diabetes care program at the institute. He also heads the newly formed Kelaram Diabetes Research Center, which is in the field of innovations in diabetes-related diagnosis and management, and the institute's learning academy. He has published the largest multi-center study of subjects with pancreatitis and pancreatic diabetes worldwide. In addition to his more than 200 publications, Dr. Unnikrishnan received the Jacob Memorial Prize for the best patient care during his MD in CMC Vellore. He has also received awards from organizations like RSSDI and Endocrine Society of India. He has received 10 awards and orations in the last 9 years, including the DTech Award for Excellence in Diabetes and Technology in May 2022 and VC Matthew Roy Oration in July 2022. Dr. Unnikrishnan has edited various journals like Indian Journal of Endocrinology and Metabolism and Journal of Thyroid Research and Practice. He is the editor-in-chief of the Journal of Chronicle of Diabetes Research and Practice. So over to you, sir.
Thank you, madam, for this kind introduction. I hope I'm audible and I hope that my slides are visible.
Yes, sir.
So thank you, and I'm going to speak about non-diabetic CKD. Is there hope on the horizon with dapagliflozin? Now, we already know that SGLT2 inhibitors like dapagliflozin are excellent drugs for glucose control. Then they became excellent drugs for diabetes control in people with cardiovascular and chronic kidney disease. Now they are becoming excellent drugs for people with cardiovascular disease and chronic kidney disease without diabetes. So that's what I'm going to talk to you about. If you see the majority of CKD, majority of people with chronic kidney disease, the majority of them are non-diabetic. As per latest statistics, you can see that non-diabetic kidney disease represents about 58% of CKD cases. Most CKD patients die before progressing to end-stage kidney disease, and cardiovascular disease is a leading cause of mortality. This slide on your left shows the probability of death or dialysis over a 5-year period.
Your voice is getting interrupted in between.
Okay, just a minute, ma'am. Let me try to adjust.
Excuse me, sir. Sir, your voice is getting interrupted in between. Poor connection.
Let me just.
Yes.
Is it better now? Is my voice better now?
Yes, sir. Now it is better.
Better, okay. So let me go ahead with my slides now. So there is a close and specific association between chronic kidney disease and the heart. This slide shows you that this slide shows you that on one hand, you have decreased cardiac output in there is heart failure, but that decreased cardiac output will lead to decreased renal blood flow, decreased albuminuria, and chronic kidney failure. On the other hand, chronic heart failure can occur from sodium and water retention, and that can worsen the chronic heart failure. Now, therefore, chronic kidney disease increases the risk of cardiovascular events. Cardiovascular disease events increase the risk of chronic kidney disease, and therefore, these two are linked. I hope I am audible now.
Yes, sir, you're audible, sir.
Yes, sir. Yes.
Thank you. Thank you. Thank you, sir. Thank you, ma'am. So if you look at no kidney disease to chronic kidney disease stage 3A to chronic kidney disease stage 5D, if you go on from one end to the other, the risk of atherosclerotic cardiovascular disease increases, and the risk of cardiovascular mortality also increases. Now, evidence suggests that if you look at cardiovascular disease, heart failure is the most important comorbidity in people with CKD and CVD. Now, if you look at people with or without CKD, again, heart failure is important. Now, let us look at a case. This is a 48-year-old male, BMI of 32, obese, no history of diabetes, no cardiovascular events. His urinary albumin creatinine ratio is 2000, so there is albuminuria. He has hypertension. He's on hydrochlorothiazide, telmisartan for CKD and hypertension. He's also on statins for dyslipidemia. The personal and family history is negative, and autoimmune screen yielded no results. Renal ultrasound showed kidneys with hyperechogenic renal parenchyma, and the urine showed heavy proteinuria. A renal biopsy showed glomerulonephritis, IgA nephropathies / FSGS. So what is the next line of management? Several studies in diabetic kidney disease are there, but in non-diabetic kidney disease, whatever you treat with, you will find that there is a residual risk. So can dapagliflozin help? So this is the DAPA-CKD study. It was a landmark study in people with and without diabetes. Around 4,000 people were taken in the study. The age was more than 18 years. The eGFR was below 75, about 25. Urine albumin creatinine ratio was 200 to 5,000. The patients were on stable maximum tolerated dose of ACE-ARB. These patients were randomized into 10 mg of dapagliflozin or placebo, and the primary outcome was composite of sustained more than 50% fall in eGFR, occurrence of end-stage kidney disease, renal death, or cardiovascular death. This was the first such study to investigate SGLT2 in people with and without diabetes. So you can see mixed population was studied in the DAPA-CKD study, and the study was a very illuminative and very remarkable study because people with type 2 diabetes showed a 36% reduction in adverse kidney outcomes, but people without diabetes, it showed a 50% relative risk reduction in the occurrence of fallen eGFR, renal death, and end-stage kidney disease. And proteinuria also came down. You can see people without diabetes, the proteinuria came down with dapagliflozin. If you see the subgroup analysis, both in diabetic nephropathy and glomerulonephritis, the findings showed a statistical significance in favor of dapagliflozin, and overall result also showed almost 39% reduction in outcomes. the number of people with IgA, like in our patient, was very high in the DAPA-CKD study. And DAPA-CKD study showed that the occurrence of adverse kidney-related outcomes in IgA nephropathy was reduced by almost 71%. The hazard ratio is 0.29, which means 1 minus 0.29 is 0.71. So a 71% reduction in adverse renal outcomes in dapagliflozin in the subgroup dapagliflozin among the subgroup of the patients with IgA nephropathy, non-diabetic kidney disease in the DAPA-CKD study. If you look at the outcomes with FSGS, again, you can see the overall composite outcome showed that dapagliflozin was better. You can see the dot here and the confidence interval here. You can show the kidney-specific outcomes was better with dapagliflozin. And if you see the eGFR decline, end-stage kidney disease, or renal or cardiovascular death, that was also reduced with dapagliflozin. Now let's look at the baseline cardiovascular disease and heart failure. If you look at the baseline compared to baseline, without CVD, overall is at the top gray color. With CVD comes next, and without CVD comes next. Now, if you see, dapagliflozin is in the dark purple color. Dapagliflozin without CVD is in the gray color. So what you will see is that compared to placebo, there was a dramatic decline in cardiovascular events with dapagliflozin, especially in people without CVD. And this was true, and the DAPA-CKD showed that heart failure outcomes, all the dots are on your left, suggesting that dapagliflozin reduced heart failure outcomes compared to placebo. So if you see the DAPA-CKD, you can see that people, only a small proportion had a significant proportion were non-diabetic. And if you see the primary outcomes, again, it showed that dapagliflozin was better than placebo. If you see just this purple color, there is a slight decline in eGFR initially in stage 2-3 CKD, but it slowly picks up and up and up. And at the end of 36 months, people with dapagliflozin do better than people with placebo, showing you that dapagliflozin preserves the eGFR. Similarly, there is a decline in eGFR in people with chronic kidney disease stage 4, and then it picks up, and eventually dapagliflozin does better than placebo. So what are the implications of the DAPA-CKD data? So there are numerous mechanisms driving the renoprotective effects of SGLT2. First is SGLT2 inhibitors, they decrease the glomerular pressure reduction by constricting the efferent arteriole. Once it constricts the efferent arteriole, the intraglomerular pressure comes down, glomerular hyperfiltration comes down, and the cytokine balance is also benefited. Second, it has an effect on neurohormonal improvements. It reduces the intrarenal renin-angiotensin system activity and reduces the sympathetic nervous system activity. Third, dapagliflozin reduces inflammation and fibrosis reduction. It reduces kidney inflammatory markers and other markers. Next, dapagliflozin and SGLT2 inhibitors improve tubular oxygenation and can also improve oxygen delivery and improve erythropoiesis. If you look at the stabilization of eGFR or reduction in albuminuria, dapagliflozin plays an important role. If you look at reduction in blood pressure, dapagliflozin plays an important role. If you look at reduction in tubular glomerular injury, dapagliflozin plays an important role. If you look at decreasing the renal ischemic injury and improving the hemoglobin, dapagliflozin plays an important role. Take it together, the reduction in interglomerular pressure, the neurohormonal improvement, reduction in inflammation, reduction in the improvement in tubular oxygenation, stabilization of EGFR, reduction in albuminuria, reduction in blood pressure, reduction in tubular glomerular injury, reduction in renal ischemic injury, improvement in hematocrit, all result in an improved renal perfusion or function with dapagliflozin. This is the practical provider guidance. Many reasons in patients with type 2 diabetes and CKD where you select dapagliflozin. I think wherever the patient requires dapagliflozin, especially if the EGFR is falling down, it's above 30, you can give DAPA, CANA, EMPA. If there is heart failure, dapagliflozin becomes a priority. If the urinary albumin creatinine ratio is high, dapagliflozin becomes a priority. Yes, there is some risk of genital infections. I have not seen foot ulcers or immunosuppression or ketoacidosis with dapagliflozin, but with good urinary hygiene and adequate hydration, problems with dapagliflozin can be prevented. Do not use dapagliflozin in perioperative or surgical cases, and always instruct patients to drink water and check their glucose on sick days. If there is hypoglycemia on insulin and sulfonylurea, dapagliflozin is a good choice. Sometimes, if the patient is also on diuretics and if the patient is elderly, you might like to reduce the diuretic dose because dapagliflozin has a benefit on that. Now, these are large studies that demonstrate unequivocally the benefits of dapagliflozin in clinical practice. The first was a DECLARE study, very large study done with more than 17,000 patients. They took patients with atherosclerotic cardiovascular disease and other risk factors and type 2 diabetes, and dapagliflozin reduced the composite outcome of cardiovascular death and heart failure death. In the DAPA-HF study, they took people with heart failure, 4,744 subjects with heart failure and EGFR above 30. And what this study showed is that dapagliflozin reduced CV death and worsening of heart failure. In both these cases, key endpoint was kidney, and kidney endpoints were improved. Finally, in the DAPA-CKD study done in people with and without diabetes, in fact, 32% didn't have diabetes, and the mean EGFR was low at 43. And the primary outcome was a more than 50% decline in EGFR, end-stage kidney disease, renal death, cardiovascular death. And this was reduced by about 39% by dapagliflozin, and the p-value was highly significant at 0.00000028. So very persuasive and highly significant p-values showing the superiority of dapagliflozin in protecting the kidney in people with and without diabetes. Also, as a side good point, it's reduced cardiovascular death and heart failure. So I've come to the end of my presentation. Let me conclude by saying that SGLT2 inhibitors were considered to be expensive. They are not expensive today. We used to consider SGLT2 inhibitors cause a lot of urogenital infections, but today in clinical practice, we don't find that many urogenital infections. In fact, it's quite rare. In fact, we don't find much side effects. We find that SGLT2 inhibitors can reduce the body weight, improve the proteinuria, decrease the blood pressure, improve the blood sugar, no hypoglycemia, weight loss is there, and now, in addition to glucose control, they can protect the kidney and the heart, and they can protect the heart and the kidney even in people without diabetes. The starting dose of dapagliflozin is usually 10 mg, and I think that these drugs, with the fact that dapagliflozin has now such a robust outcome with both heart, kidney, and heart failure and cardiovascular disease, and with the evidence in non-diabetic kidney disease suggests that these drugs, dapagliflozin, probably the only SGLT2 to be used in a wide variety of outcomes in the primary prevention setting, secondary prevention setting, cardiac protection, kidney protection, and even without, in people without diabetes, it seems to give this benefit. Let's hope that we continue to use these drugs for the benefit of our patients so that people with diabetes can not only control their blood glucose, but can also get additional protection from the heart and the kidney with the appropriate use of SGLT2 inhibitors like dapagliflozin. Friends, thank you for listening to me. It has been a pleasure discussing this topic with you. If there are any questions, I'll be glad to answer them. And there is a question here. Sir, does it help in CKD due to polycystic kidney disease? Well, theoretically, there are some publications to support it, that it may have some marginal benefit, but definitely it's good medical management is ideal for these patients rather than depending on dapagliflozin. But yes, it may have a protective role in all kinds of CKD, but specifically in IgA nephropathy and focal segmented glomerulosclerosis, it seems to have a better benefit. If there are any further questions, I'll be happy to answer them.
Thank you very much, sir. I think there is no question from here. I can see. Welcome, ma'am.
Yes.
Hello.
Yes, thank you, sir. Thank you for your lecture, sir. Dapagliflozin is really a wonder drug because myself is taking that. I'm a diabetic since last 20 years, and it's a very good drug. Thank you, sir. Thank you for your elaboratory talk. I request our President, Madam, Dr. Meenakshi Deshpande, to felicitate you.
Thank you, Dr. Unnikrishnan. And please come to IMA Pune whenever it's possible for you.
Definitely, ma'am.
Yes, sir. And it was a real, I mean, this AstraZeneca and all the speakers are so good. I mean, they are giving eye-opening lectures on diabetes, and we are coming to know more and more intricacies about all diabetes management. It's a very good sign for all IMA Pune members also that they're getting educated about diabetes. Thank you, sir. And this is an IMA Uparna for you.
Yes, and
Thank
all
you,
welcome faculties in the subject, even cardiologist and diabetologist and nephrologist, everyone. So thank you very much, sir. So can we have a discussion? Anyone?
Any panel discussion anyone is going to have?
There is one question, sir.
Yeah.
Sir, does it help in CKD due to polycystic kidney?
As I said, there are some animal studies to support the use of this. Because if you see, there are some animal studies which support that, because adult autosomal dominant polycystic kidney disease accounts for almost 5% of the end-stage kidney disease population in countries like the United States. And there are some animal studies which say that they may promote erythrocytosis and may offer a novel pathway for treatment of anemia in autosomal dominant polycystic kidney disease. But since further data is not available to understand the effect of these drugs on the cyst development and growth, I suggest that we wait for more outcomes. And I think that more research is needed for looking at SGLT2s in these patients, especially to look at the cyst outcomes and the cyst growth in autosomal dominant polycystic kidney disease. So more research is needed. It could have a benefit theoretically, but right now we require more clinching evidence. But for IgA nephropathy and focal segmented glomerulosclerosis, there is a good amount of data supporting its use. And remember, sometimes we require more data to be 100% sure. So I think these two areas, chronic kidney disease, non-diabetic chronic kidney disease, especially these two areas, FSGS and IgA nephropathy, DAPA may have a role. could have a role there.
Thank you, sir. Thank you. Can we have a discussion? Other speakers are there available? From the delegates, you can ask, write the question. We will ask sir to answer. I think there was the only one question. So I think there are no more questions. So can we come to the end? Yes. So thank you very much, all the speakers and AstraZeneca, for your well support to this nice lecture series of recent trends in cardiorenal disease management by expert specialists and all well-known faculties. So I thank AstraZeneca, especially Mr. Pankaj Kasar and all other his team. Though in the beginning there was a bit technical problem, but then it got through, because this was the first time when Right Light Media, Mr. Piyush started his this communication with us. Otherwise, before he had worked with DigiShield, so he has the experience. He is an expert, but there are some pitfalls, and yeah, and I think they were on the other side. The slides were not moving and all, but otherwise, overall, it was a very good experience. So thank you very much. So thank you all the speakers. Thank you, Dr. Unnikrishnan, and thank you all the speakers. So I take your leave.
Yeah, I think we are having a panel of consultants over here. So we thank everybody from IMA Pune, Dr. Shirish Sathe, Dr. Hemant Kulkarni, Dr. Anuja Mule, Dr. Srirang Godbole, Dr. A.G. Unnikrishnan, and of course, Kasar and AstraZeneca people for this wonderful online webinar. Thank you very much. We will end the webinar.
Thank you very much.
So please, please get registered for Multicon very fast, because we are extending the date till 10th of this month. So please.
We are extending the early bird charges for 10th of December.
Okay.
Correct? And Multicon is going to be only physical, mind you. It will not be online.
And it's an annual conference of IMA Pune. So please do join. Thank you. Thank you very much.
Thank you. Thank you.
Thank you. Bye.